Thank you so much for having us today. I'm Kevin Carr. I'm the director of the Arlington Children's Chorus. This is our 10th season in Arlington, and we're so pleased to be here with you. This is a very near and dear organization to me. I serve as principal of a summer school that is directly serving special needs students, so this is really an honor for me and all of my kids here. So thank you so much for having us. We're going to sing probably 15 minutes for you, and at the end, if you have any questions, we'll be happy to answer those. Thank you.
So good afternoon. Let's begin our afternoon program by recognizing this incredibly talented group of youth and their leaders who have provided our afternoon entertainment. I'm going to tell you a little bit about them. The Arlington Children's Chorus was founded in 2010. They're directed by Kevin Carr, who is an experienced music teacher of children in Arlington and director of children's choruses for over a decade. The chorus is a nonprofit dedicated to providing enriching choral music instruction to children in grades 2 through 12. Children come to the chorus with many gifts, voice types, musical experiences, and personalities. But the program provides much more than an education in musicianship. It incorporates lessons in math, foreign language, and literature, as well as developing invaluable skills in discipline, poise, and teamwork. Please join me in another round of applause for these talented youth and their leaders. So I am really excited to be here with you all to kick off our conference. I'm Michael Warren. I'm the current board president for AMCHP. I'm a pediatrician, and I work with the Tennessee Department of Health. And we are thrilled to welcome you to our annual conference and to introduce this year's theme, Staying Focused, the Enduring Commitment of MCH to Families and Outcomes. When I think about that theme and the work you all do every day, the theme really sums it up. At the end of the day, we are focused on families, whatever the constitution of those families, wherever they are, and whatever their circumstance. We commit to serving them, and we do so with a focus on outcomes, assuring that what we do is what our community wants us to do in order to move the needle on priority issues. And sure, there are things that make that work more challenging than others sometimes. Things like extreme weather, changing political and cultural environments, staff vacancies and shortage. All of these things can make this work more difficult. And yet you continue to persevere. As MCH professionals, you stay focused with an enduring commitment, and for that, we are all grateful. I think you're really going to enjoy this year's conference. There are over 900 of you here, and that sets a record for us for AMCHP for DC conferences. While you're here, you'll have the opportunity to choose from over 72 workshops and skill-building sessions, meet over 100 poster presenters, and visit with nearly 40 exhibitors. I'm particularly excited about some of the general sessions that you will get to experience. There's one on family engagement in MCH. There's one on learning from disasters and how we can be prepared to handle emergencies with a particular focus on the MCH population. There's one on engaging males, fathers, young men, and adolescents in our work. And then there's a closing address on the future of maternal and child health. You'll also get to hear from our MacQueen Lecture Award winner and one of my pediatric heroes, Dr. Richard Antonelli. Such an awesome conference doesn't just happen. What you will see here over the next few days is the result of planning that has been going on for a year. Literally, once one conference ends, the next day we start planning for the next year's conference. So please join me in a round of applause to recognize the work of the AMCHP staff and the Volunteer Conference Planning Committee for their outstanding work. Speaking of outstanding work, I want to tell you a little bit about what the AMCHP staff have been up to this past year, and this is just a teaser for what you'll hear later in the conference. But they really are busy every day working on our behalf and the behalf of children and families across the country. From a program perspective, just a few of the things they've been involved with this year include helping states respond to the Zika virus, focusing on maternal mortality and how states can implement maternal mortality reviews effectively in their state, and general activities around workforce development. From a policy perspective, there's been a lot for them to think about, and in the past few weeks in particular, a lot of work on the federal budget and the continuing budget resolutions, and we're excited to see the prominence and the stability and funding for the Maternal and Child Health Block Grant and the continuation of the McV funding. And then from an operations standpoint, they have new digs. They settled into a new office over the past year and a half. And importantly, I think for those of us who trust them to do their operations on a daily basis, they've just come out of a full audit by a brand new audit firm. And usually when you have a new audit firm, they'll find something because they're incredibly picky and they want to find opportunities for improvement. We had 0 findings by a new audit firm, which is fantastic. So we really are appreciative of the work of AMCHP and the staff. You'll be able to hear more about the work of your association at our AMCHP business meeting, which is Tuesday morning at 7:45 in Salon H. This is particularly important if you're a delegate. So if you're not sure if you're a delegate, if you'll talk to your state MCH or Title V director, important for you to be there. And this is where we review the activity over the last year of AMCHP, get an update on things like the financial report, and an opportunity for you to vote on important matters. Before we get too much into the afternoon program, I want to recognize a few groups. The first is our AMCHP Board of Directors. These are the folks who represent you. They are 19 strong and come from your states and territories and provide you with a voice in the direction and operation of our association. We have a representative from each of the 10 HRSA regions, 2 family delegates, 2 at-large delegates, and 5 officers. If the board members will please stand. Please join me in thanking them for their enduring commitment to MCH. I'd like to give a particular thanks to the executive committee of the board of directors. These individuals are officers of the board and are particularly active in guiding the operation of our association. I'll ask each of them to stand as I call their name, and you can then join me in applause after I've introduced them all to you. You may want to also note these are all women, and many of them mothers who have guided a man in being president this year, and it's been really exciting. And really, I'm really grateful for their support because they make the rest of us look good. So first, Eileen Forlenza from Colorado. Eileen's our past president and first family delegate to be president of AMCHP. Susan Chacon of New Mexico, who's our president-elect. Susan is state CYSHCN director in New Mexico. Also, Susan Colburn from Alabama, who's our secretary. Susan is the state parent consultant for the Children's Rehabilitation Service there. And then Karen Downs from Massachusetts, who's our treasurer. Karen is the MCH director in Massachusetts and also the director of the Division of Pregnancy, Infancy, and Early Childhood. And I really appreciate their friendship and support over this past year. Also want to take a moment of personal privilege to thank my colleagues who are here from Tennessee. They are incredibly hardworking, passionate, innovative, and the children and families in our state are very lucky to have them working on their behalf every day. When I committed to this 3-year term, it's a year of president-elect, a year of president, and then a year of past president, I sort of committed them too, and I don't recall asking them for that commitment because I get pulled away for lots of various things, but the work has to be done, and they're the ones who keep that running every day. They make sure that children and families in Tennessee are able to thrive. So if you're here from Tennessee, please stand and let the crowd around join me in a round of applause for you. Finally, I'd like to thank all of you. Thank you for taking the time to be here with your MCH colleagues from across the country. I encourage you not just to be here, but to be engaged here. Think about all the different ways that you can interact with, learn from, and teach your colleagues while you're here. Some examples of those might be participating in our Q&A sessions, visiting our posters, attending the networking breaks, chatting with our exhibitors and sponsors, and of course sharing your presence on social media. Our hashtag is AMCHP18. Some of you have already been very active with that, so keep those coming throughout the conference. It is my pleasure at this time to introduce our next speaker, who is the administrator of the Health Resources and Services Administration, HRSA, Dr. George Saguna. As the lead agency for Title V programs, HRSA is the governmental agency focused on improving health care to people who are geographically isolated, economically, or medically vulnerable. Dr. Saguna became the administrator for the U.S. Department of Health and Human Services, HRSA, on May 1st of 2017. HRSA's $10.5 billion annual budget expands access to quality health care through an array of grants to state and local governments, healthcare providers, and health professions training programs. Before coming to HRSA, Dr. Saguna spent 23 years as professor of medicine at the East Carolina Brody School of Medicine in Greenville, North Carolina, where I attended medical school. Go Pirates! During that time, he served as an inspector for the Foundation of Accreditation of Cellular Therapy and established the bone marrow transplant program. His work with the bone marrow transplant program also provided him with extensive experience with designing and conducting clinical trials, preparing patient treatment protocols, and performing fiscal management. From 1987 to 1994, he was a scientist and researcher at the National Institutes of Health and the Naval Medical Center. For more than 30 years, he has been teaching and training a broad spectrum of students, including undergraduates, graduates, medical students, residents, and fellows. He earned his Bachelor of Science degree in Biology and Chemistry from the University of Patras in Greece, a Master of Science in Physiology and Biology from Northeastern University, and a PhD in Cell Biology and Physiology from Boston University. Welcome, Dr. Saguna, and thank you for taking your time to be with us this afternoon.
Thank you, Dr. Warren. I was very happy to be here and see this wonderful group of young children singing today. It is very uplifting. Also, with Dr. Warren, we have the common theme there. He was trained in the place which I served as professor for 23, 24 years. The only difference is that we trained Dr. Warren to support the healthcare in North Carolina, but Tennessee seemed to attract him more. But anyways, he's doing a wonderful job, and thanks for that. It is a pleasure to be here this afternoon and speak with you all who work on behalf of maternal and child health populations on the state and local levels. I have a tremendous respect for the work that you do to improve the lives of our nation's women, infants, children, including those with special healthcare needs and their families. Thanks for your commitment and dedication. As many of you may know, HRSA's mission is to increase access to healthcare for people who are medically underserved and geographically isolated. We do this through providing grants and cooperative agreements to more than 3,000 awardees, including community and faith-based organizations, colleges and universities, hospitals, state, local, and tribal governments. Every year, our programs serve tens of millions of people, including pregnant women, mothers and their families, people living with HIV/AIDS, rural Americans, and those otherwise unable to access quality health care. These programs include HRSA's Maternal and Child Health Title V Block Program Grant, which has played a vital role in advancing the health and well-being of our nation's mothers, children, and families for more than 80 years. In fact, our most recent data shows that over 3 million pregnant women and nearly 51 million children across the country benefited from public health services and systems supported by this block grant program. Title V has been a long-standing and significant funding source in improving access to quality health care for mothers and children in all 50 states, the District of Columbia, and the 8 territories. Let me highlight just a few of the many successes in which Title V has played an important role. First, access to health services for pregnant women has improved, with an 8% increase in early prenatal care in the United States between 2007 and 2015. not only are more women receiving early prenatal care, but states are increasingly working to improve access to preventive and primary care for all women of childbearing age. It is just 8%. I like and I challenge you to increase that rate. I would appreciate it. Second, the US infant mortality rate declined by 15% between 2000 and 2015. I thank you for doing that. I thank you for trying to decrease the infant mortality, and please continue decreasing this rate even more as we go. The data also shows that more women are breastfeeding. In fact, the percent of mothers who breastfed their infants through 6 months increased by 60% between 2000 and 2014, with over 55% of mothers breastfeeding in 2014. Additionally, the percent of uninsured children reached a record low of 4.5% in 2016. So these are great news, although we can do a little better in all these areas. While we'll celebrate the successes, HRSA, along with the maternal and child health community, recognizes that there are many challenges facing us. Based on national vital statistics data, maternal morbidity and mortality are increasing. An increasing number of pregnant women in the United States have chronic conditions such as high blood pressure, diabetes, or heart diseases, which put them at high risk of pregnancy, complications, or death. We are one of the bottom countries in the Western civilization regarding that area. In response to this important issue, HRSA will be hosting a 3-day maternal mortality summit in June of 2018. This summit will bring together leading domestic and global health experts to identify potential strategies for improving maternal health outcomes. Another significant challenge facing our nation is the opioid epidemic. Opioid addiction is a public health crisis, and we have seen rates of neonatal abstinence syndrome in infants quadrupling over the past decade. Obesity is another serious problem in the United States, putting individuals at greater risk for poor health. While there has been progress in curtailing early childhood obesity, overall rates remain high nationwide. In the United States, more than 1 in 3 adults and more than 1 in 6 children are obese. Data also shows rising rates of mental health disorders. including anxiety and depression, and suicide among our nation's youth. Title V can help us with those challenges. These challenges could be addressed through data-driven programs and implementation of proven strategies through the Title V program. Our common goal is to improve the health and well-being of mothers, children, and families through establishment of family-oriented, comprehensive system of care. The federal-state partnership is strong. Through our combined efforts, we can accomplish a lot. The balance between program accountability and flexibility for states to determine their individual maternal and child health needs may result to the best use of available resources. Title V remains a positive and leading force in promoting quality health care for all mothers and children across the nation. As you continue your work, please keep in mind that HRSA is a committed partner. Effective and efficient maternal and child health programs can be developed through our shared responsibility in providing thoughtful leadership at federal, state, and local levels. Thank you again for the opportunity to speak with you today, and I wish you a great success in your efforts.
Thank you, Dr. Saguna. And along with the theme of this conference, Enduring Commitment, we truly appreciate the enduring commitment of HRSA and the Maternal and Child Health Bureau. They are invaluable partners in helping us to move the needle and improve those health outcomes. You heard Dr. Saguna mention a number of those where we've seen remarkable improvement, which is truly a result of that partnership, the MCH Block Grant, and want to also thank the work specifically at HRSA of the Maternal and Child Health Bureau, Laura Kavanaugh and her team, who are tremendous partners with us and support us in this work every day. It's now my pleasure to kick off our program and introduce one of our most prestigious awards. It's the John C. MacQueen Lecture Award for Innovation in the Field of Maternal and Child Health. This award was established in 1988 to honor one of AMCHP's most distinguished members, Dr. John C. MacQueen. The unique aspect of this award is that the winner presents an inspirational lecture to our attendees. To give this segment the appropriate context, let me briefly tell you about Dr. MacQueen. He was the former director of the Iowa Child Health Specialty Clinics, the state program for children and youth with special health care needs. As a pediatric neurologist, he achieved success at state and national levels. As an administrator, clinician, advocate, innovator, and educator, he made his presence felt across the country through his tireless work on behalf of children with special health care needs. We are so pleased today that this award honors Dr. MacQueen's legacy, and we're even more thrilled today that it's being awarded to Dr. Richard Antonelli. Dr. Antonelli is the Medical Director of Integrated Care and Physician Relations and Outreach for Boston Children's Hospital. He's also in the faculty of Harvard Medical School in the Department of Pediatrics. Between 1987 and 2005, he was in full-time community-based general pediatrics, founding Nashaway Pediatrics in Sterling, Massachusetts. Since 1987, his clinical work has focused on providing comprehensive, family-centered care for all children, youth, and young adults, but especially for those with special health care needs. His many accomplishments include publishing data about the outcome, efficacy, and cost of care coordination services for children and youth with special health care needs and their families, specifically in primary care settings. His work defining mechanisms for integration and coordination of care across systems, including the development of strategies and interventions to improve collaborative efforts between families, primary care providers, and subspecialists. He and his team are extending their work to measure how families and non-physician care coordinators work to support the transition from pediatric to adult systems of care. He served on the steering committee for care coordination at the National Quality Forum and as an advisor to the Patient-Centered Medical Home Measurement Tool Work Group at the National Committee for Quality Assurance. He's a member of the Advisory Council to the National Center for Family and Professional Partnership Center. He represented the Academic Pediatrics Association in the national initiative establishing a policy-relevant research agenda for the patient-centered medical home, a multidisciplinary approach. And the care coordination measurement tool was developed by him with funding support from the U.S. Maternal and Child Health Bureau. Use of this tool enables measurement of the activities of care coordination, the necessary resources to implement those activities, and the resulting outcomes. We could spend the rest of the afternoon talking about his accomplishments, but you would much rather hear from him. So I'll tell you just a bit more about his current work. He continues to have general pediatric clinical responsibilities in the primary care clinic setting at Boston Children's, where he also teaches residents, students, and fellows. He still is the primary care provider for several patients who have been with him since he first completed his residency. He has spent his entire career in the tireless pursuit of coordinated, compassionate, family-centered, culturally competent care for children and youth with special health care needs and their families. Please join me in welcoming to the stage our John C. MacQueen Award winner, Dr. Richard Antonelli.
And when I started as a pediatrician, I never expected anything like this. So let's get going. Here we go. So, high-value outcomes in maternal and child health. My presentation today is going to be infused with lots of story. Another one of my Ohana references from Hawaii. Lots of contact with people, the things that I've learned from people, the things that infuse my work. Also opportunities. The theme really coincides perfectly with staying focused. And that theme is what can each of us do tomorrow, next month, next quarter, this year. Believe it or not, there is huge opportunity if we stay focused and implement. We're going to talk about that, and then I'm going to end with a challenge for AMCHP and the MCH community. So the first thing that I want to share is from an 18-month-old. Benjamin Pascal Antonelli was with us in the kitchen, and he said something like, And I asked his mom and dad, what is it? Oh, he said, reach 'em. Reach 'em is Benjamin's way of, in fact, doing just what that is, reaching out. It means Benjamin wants to engage. It means Benjamin would like to do something jointly. That sometimes means reading a book. That sometimes means saying a blessing before a meal. And sometimes it means kayaking together. Benjamin is now 2 years old. And Reach 'em sticks with me, and I hope at the end of this presentation, you'll know how to operationalize Reach 'em on our journey. So I never had the privilege of knowing Dr. MacQueen personally, but oh my word, what a resume. And then I realized as I was learning about that to prepare for this, I owe this man a debt of gratitude. And so, because I also know he was well known for his limericks, I got up at 4:30 this morning, so hopefully this will be coherent. There once were many children with special needs. whose families were seeking empowering leads. Integration of resources would help them thrive. We can't achieve high value without Title V. And assuredly, we collectively will succeed. Now let me take you into this world and talk about this. So what is it about the MCH community that I really love? It's the stakeholders. This is the only organization that I know of that is interprofessional, but that families are a key component of being stakeholders. We don't happen to invite them in because we've already defined the agenda. No, we need families to sort of weigh in and tell us how smart we are. They are part of the process. And it's a strength-based approach. I can tell you medical school is very much a deficit-based approach. What's wrong with you that I can help today? How can I fix you? That implication of disease underlies a lot of medical training, and it affects and impacts our culture as physicians and healthcare providers. But MCH, and I'm going to argue true family-centered care, requires a strengths-based approach. What is your strength, and how can we provide you with the necessary skills and resources to move forward? And the vulnerability of the people that we serve. The work is noble, it's dignified, it's challenging. People say you work too hard, and I said, you know, if I ever measured how hard I work by my clock face, then I need a new job. So is it hard work? Yes, but that's a measure of joy. And finally, it is a privilege to serve. And I choose that verb very carefully. It is serve. It is serve. So take-home points. For those of you that want to go and watch a basketball game, all you got to do is get through this slide and then you can leave. Integration is essential for achieving optimal value. Value is quality with some measure of cost. What am I buying for this? What am I getting for it? Care coordination is necessary, but it's not sufficient to achieve integration. Success requires patients, children, families, and caregivers as full partners, not tokenized customers, but really drivers, co-creators, co-producers of the services. And that's at the individual level and at the systemic level. The medical home is necessary, but it's not sufficient. Lots and lots of evidence that suggests that. That doesn't mean that the medical home is not a great model. It is, but it's not enough in the space around integration. And community linkages are critically important. Title V, family to family. Family to family, as far as I'm concerned, is such an underutilized resource across healthcare delivery systems. We have to work to change that. So now I want to tell you a story. Last summer, the Antonellis were on vacation. Our 9-year-old woke up and was actually quite ill. So ill that I said to my wife, maybe we should drive back to Boston. And as we were packing up, I said, you know, let's just call the PCP. So we did, and the PCP says, no, I'll get the records there. You go, and then we'll back you up. So we went. Introduced ourselves to somebody in the local region. Had already heard from the PCP in Boston, engaged us in a conversation that included several treatment options, respected the fact that I was quite worried as a layperson, but also knew quite a bit about what she was trying to say, and respected that totally, and we landed in a good place. And as if that isn't enough, the next morning we get a call from the PCP in Boston. How did it go? Is there anything else I can do? So let me introduce you to our 9-year-old. That is Kai. Care plans? Why is this so difficult for human medicine? I wish that every billboard that you saw out there that was espousing how great delivery systems are would actually have that kind of explicit language. Here's how we're going to engage you. Here's how we're going to empower you. And for those of you that know me, and certainly my students, I don't want to talk about satisfaction. I want to talk about your experience, because we need to let the families know what they deserve and what they can expect from us. And then I'm willing to talk about satisfaction. So I'm going to pivot a little bit and tell you about a true story that is with me literally every day, especially when I talk to quality and health policy audiences. Miguel, brand new patient, 4 years and 3 months old, came to our primary care center at Boston Children's Hospital. He was newly transferred to us. He actually was in, I would argue, one of the best medical home practices in Boston. And over the course of the 4.25 years of his life, had been touched by every single academic medical center in Boston, multiple visits to the emergency room. His primary care provider had made an accurate diagnosis of reactive airways, for lay people, that sort of a version of asthma, at the first birthday. But there was something that was sort of niggling at people. Something about his attention, something about his development. The primary care providers noticed it. The emergency room doctors noticed it as well. Had come to us after 3 trips to the emergency department in the prior year, 4.25 years old. The intern that precepted with me that day literally was shaking when he precepted. In fact, Miguel, in the middle of arguably the most highly resourced medical spot in the United States, had autism. Why am I sharing this story? Stay tuned for the next click. Every single quality measure known to American healthcare scored an A, because they were all one-sided handshakes. The primary care provider knew the child had a developmental issue and made a referral. Check. Emergency room doctors assessing his respiratory status and his asthma also noticed there was something developmentally and mentioned something to the mom, oh, you should get this checked out. Check. Primary care providers refer to early intervention. Check. What's wrong with that kind of measure? This audience, unfortunately, is way too big for me to sort of go into my usual Socratic mode, but the answer is just what I said. Measures of care coordination, by which Dr. A simply transmits a patient to agency B or provider B. We have to get beyond that one-sided handshake in order to really move toward integration. So think about Miguel. Think about the status of care coordination and care quality in this country. And I chose Miguel specifically because there was a role for early intervention. And it's not that it wasn't there, it's the family didn't know how to navigate a system. So I do want to pause, and I'm not going to tell the stories behind every one of these names, but I feel so privileged. The folks on the top line are my inner, ooh, all right, am I supposed to memorize my slides? There we go. All right. You know, the Patriots didn't win, so you don't have to do that. So my pantheon of people that taught me what family partnership is all about are right there. And I thank every one of them, and in particular a shout out to Nora Wells. She came out to my practice in Sterling when I thought the world was falling apart. I was accused by insurance companies of attracting kids with complex needs and that I should start screening those calls and saying, please, we're closed. Nora said, we can do this. And hence, I have had a privileged relationship with Nora and with Rich Robson and with Leo and Josie and then the Bureau. You know, I can't say enough about the USMCH, Marie Mann, Merle, and Bonnie and Linda, and just, you know, you folks have been such a North Star for me at the federal level. And then, you know, Cal and Carl, Jeff Schiff, he calls me his Italian brother, and I suppose that makes him he is my Jewish brother. But Jeff's a Medicaid leader in Minnesota, and we're going to talk a little bit about that. So by design, I want to show you the heterogeneity of my inner circle. I discovered Title V years after I left residency. Debbie Allen at the time was the special needs director in Massachusetts and allowed me to consult in the program, but I honestly had never heard of Title V in medical school. And frankly, I don't know whether it's taught now, except for those of us that are subversive enough to infuse it in there. And then my patients and their families and my students and innumerable other ones. So thank you to all. So now's the picture part, right? This is the group in Washington that set the stage for a series of papers that are coming out on special needs, children with special needs and policy. Aloha. Part of the reason that I have to blow out of here at the top of the hour is I'm going back for my 5th Cal SIA visiting professorship in Hawaii. It's funny how I kind of move that into February every year. And this is Jeffrey. What I'm about to say is a true story. Jeffrey died 2 weeks ago today. 35 years old, was really never supposed to make it out of the newborn nursery. A brain malformation, and Jeffrey was medically homeless. His mom was a nurse. Mom is a nurse. And we were around the bed in the ICU 2 Sundays ago, and Mom looked at me and said, "Is there something that I can do to help the cause?" I said, "Well, you know, I've got this gig in 2 weeks." And so she not only gave me permission to share this photograph, but to bring it forward to honor Jeffrey. There are a lot of Jeffreys out there. Crossing that threshold from pediatrics to adults, systems of care is frightening, and especially if you're as vulnerable as Jeffrey is. This is another one of my heroes and mentors. This is Evan. This is Evan and Sarah. I diagnosed Evan with autism when he was 15 months of age. Evan is now an adult who also is medically homeless, although I have the privilege of being his medical home provider. Sarah works in a transplant unit as a nurse and is the best advocate that I've ever seen for her brother. This is Glenn, Patty Hackett's son. I met Glenn. It's funny, everybody thought that it was Stephen Hawking, and then, which always made Patty very proud. But Glenn taught me a lot about families digging down deep, finding their strengths, building on their strengths. This is Glenn, the first time Patty brought him in his wheelchair to the ocean, and that look of joy on his face is just as the waves were lapping the bottom of his wheelchair. Patty and Alex. This is my Hawaiian sister on the right. That's Leo Linda. And the person on the left I'm kind of close to as well, my wife of almost 40 years, who also is actually a research partner with me. And this is Blue Sky Day. Does anybody know what Blue Sky Day is? Blue Sky Day, every year across the country, a condition called Rett syndrome. It's a genetic disorder that almost exclusively affects females. we all convene the Rett Syndrome Association of Massachusetts, organized by the families, with the families, for the families, and the providers are secondary, but we're all here. These are the steps to Harvard Medical School. And the ceremony actually involves, for those girls and those women that are able to ambulate up the stairs, we cheer them on. And for those that can't quite do it under their own power, there are people that help them. We have local fire department. Last year we had the folks from the USS Constitution, the volunteer force there, would carry the wheelchairs up the stairs. And it is one of the most profoundly inspiring activities that I have that reminds me of my privilege as a provider and as an advocate. Of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. Be mindful of this. I'm going to show you some compelling data now behind that. But before we go there, I want to share some wisdom. Because remember, the theme of staying focused, I'm going to bring it to what can we do right now. And I'm starting with Kari Coleman. I've never met this woman, but I know all about her. She's working with us on a project. I think she's coming tomorrow. I believe that so many of our solutions are simple. Be human, communicate, build relationships. We have a tool to measure that. More to come. The Pediatric Integrated Care Survey project that you'll hear a little bit about, but I wanted to offer this quote. A family member shared with Hannah Rosenberg from my team at Children's and who manages the National Center for Care Coordination Technical Assistance. The family person said, connecting to the Federation for Children with Special Needs, which is Massachusetts Family Voices, quote, 1 million doors opened up. Connecting to community resources, I found allies for advocacy. She had to find it on her own. And when we were building the PICS instrument, we had these kinds of stories saying, where was this information? Why didn't I get it sooner? And it's information. Notice that mom didn't say, I wish there was a more expensive MRI or a new drug. Zip code versus genetic code. From my perspective, this is one of the most compelling statements of life, in particular in the United States. Your life outcomes are correlated with a zip code into which you are born. And yes, I said born, not live. I wish it was correlated with the zip code in which you live, because at least in theory, you'd have some power over that. But in fact, the zip code into which you are born. Think back to our Martin Luther King Jr. quote. And in fact, this is data from a study done in Boston, the Place Matters Project. And within that environs of Boston, there's a 33-year gap in life expectancy between the higher and the lower socioeconomic statuses. This is a paper that I have had the privilege of working with a group at the Boston University Center for Innovation and Social Work. Sally Bachman, who I assume is out there, I can't see with these lights, but if you're there, thank you. But Jeff Wilkinson is somebody that led this group. No equity, no triple aim. We don't have the right to declare victory on health care without a measurable reduction of disparity. You'll see the red box there. The red box there is, yeah, there's a few docs in there, but there's attorneys, there's social workers, there's macro social workers, there are advocates, community health workers. This was so important to get into the American Journal of Public Health. I encourage you to read it. We can't lose our focus about disparities. When you think about life course and you think about zip code into which you're born, we have an obligation across the entire population to measure and to move for policies to reduce disparities. Here's Kristen Lind. Here's Gabe. I'm going to go quickly through her care map. I am so proud of, this is literally now around the planet. It's in multiple media presentations. Kristen and I were working one day, and she had to go home to do stuff, and I said to her, you have a busy life. Any way you can show me what it looks like? And this is that so-called care map. We're actually working on building an electronic version of this right now. It is held by, curated by the family. The family can identify who their care team members are. And this is powerful because it will significantly shift the center of balance for families. This is real data from Boston Children's Hospital. I decided one day I wanted to look and see who are the kids that we spend a lot of resources on, and what is it that we should be thinking about at a broader level, not just at the individual level, but thinking about populations and subpopulations. So this is what I call my complexity pyramid. Tip top, neurodevelopmental disorders including autism, significant behavioral and psychiatric conditions, hematology, oncology, sickle cell, hemophilia, technology-dependent children, multiple chronic conditions, significant social risk factors, and adverse childhood events, multiple ACEs. The middle of the pyramid, significant overlap, once again, with behavioral conditions, in addition to asthma, obesity, diabetes, and once again, those ACEs and social risk factors. So think about this as we now transition to the next slide. Look at the allocation of resources. 0.5% of the population is responsible for 25% of all of the money spent. The middle of the pyramid is about 25% of the population. That's receives 70%. So basically that means that 25.5% of the pediatric population, what those of us in the MCH community would call CYSHCN, is 95% of this expense. And 3/4 of the population gets 5% of the resources. And then think, using this paradigm, think about how primary care has traditionally been engineered. High volume, 20, 30, 60 kids per provider per day, fee for service. You keep the lights on by working on volume. Is it any wonder that if you have chronic condition or conditions, you're going to slow that conveyor belt down? And that's why we have so much fragmentation. It's one of the reasons we have so much fragmentation, and one of the reasons that people like I and others are trying really hard to re-engineer primary care. In fact, my residents at Children's in Boston and at Boston University Medical Center, we call it 21st century primary care. We're moving into the realm of, if you're a primary care provider, you will be comfortable with complex care. We will teach you the tools, the lexicon, the multidisciplinary approach of care integration. It's more than reading a textbook. The traditional approach of, if you just pay doctors more, they'll do a better job. Families are tired of hearing that. Policymakers are tired of hearing that. And frankly, I am as well, and we have the data. So Dawn and I did a visiting professorship last year in Australia, and we were running to go somewhere in Sydney to somewhere, and I just stopped. I said, wait. And of course, that subway door closed and we missed the subway, but I had to take that picture. Why do you think I would have taken that picture? Because the engineers that built the subway system in Sydney wanted to warn people that there's a potential hazard up ahead. Mind the gap. So let's talk about gaps in American healthcare. I had the privilege of doing some work with a group in Massachusetts called the Parent Professional Advocacy League, PPAL. And we did a study of 200 families with children that had behavioral health needs. All of those kids were in medical homes. That's the denominator of this measure. All of them had medical homes. 86% of the time, the families were singularly responsible for coordinating the care when their children needed behavioral health services. Now let's back out of behavioral health and let's put in congenital heart disease. What percentage of the time are families on their own coordinating care if there's a traditional medical problem like heart disease? It's pretty darn close to zero because their systems are designed to be pretty generally efficient within their silos. Behavioral health by itself breaks that paradigm. Fragmentation leads to inefficient and even less safe care. It impacts families, more likely to leave or reduce your work hours, more likely to split relationships. And on the commercial side, guess what? Groups like the National Business Group on Health, the AFL-CIO, they want to defragment healthcare. So I would encourage the MCH community as you move forward around value optimization. We won't take our eyes off of Title V block grants. We won't take our eyes off of the Medicaid opportunities and CHIP opportunities, but don't forget the commercial populations. They comprise a significant stakeholder voice because it costs those employers more when families who have children with special health care needs are otherwise distracted. Absenteeism is self-explanatory. Presenteeism means that parent comes to work but is so busy trying to find a therapist for his or her child. So presenteeism is a problem. Please keep them in mind as a potential ally in our work. So care coordination, operationally, I think of as the set of activities in between, the space between. Between visits, providers, and hospital stays, we had the privilege of writing that language into the American Academy of Pediatrics policy statement. But integrated care I've defined really as an experience measure. It's the seamless provision of health care from the perspective of the patient and family across the continuum. You can read the rest of that sentence, but basically what it means is families don't just think of an institution. They think about the entirety of the care team. So we received some funding from the Lucille Packard Foundation for Children's Health a few years ago, and I shared that definition, and then I realized it's one thing to make a definition, but how do you measure this? And so I'm going to give you a quick snippet of how we measure integrated care. But first, some comments from the focus groups. Families, Boston, Palo Alto, Stanford, because that's where the funding came from, so bi-coastal, English and non-English speaking families. This is what fed back to us. What does integrated care mean to you? A knowledgeable professional taking some responsibility for a holistic look at my kid. That was their word, holistic. Don't just think of my child as a disease or a diagnosis. Help with prioritizing. Which crisis do I do first and then next? To really know that everyone on the team has a good working relationship. There's an element of trust between the patients and families and the care team, but the care team members respect and communicate as well. And someone who clears the path for me. And I love sharing these 4 bullets. These play well in any kind of policy environment. Nothing there said, make my life easier. Nothing there says, take the burden from me. Everything there, it is moving away from a dependency model to an empowerment model. And that's what the experience of integrated care is all about. This is the framework for care integration. These team-based care, the components, do we have the right people on the team? Team configuration, communication and knowledge sharing. So not just simple cut and paste data. Don't say you have access to the EMR, all 1,000 electronic pages. There is a difference between data and information and communication, and families know that, even if they don't necessarily use the right taxonomy. And connecting to life in the broader community and future. Families didn't even want to talk about care planning because that felt too medical, and I totally get that. So they actually just wanted to say, it's my kid's future. So short and intermediate term goals. So the 5 domains of integration: access to care, and that doesn't just mean the next visit. Care also means timely access to information. Communication between the family and the care team. The impact on the family. Care goal creation and planning. And team functioning and quality. The PICS is free. It's in the public domain. Funded by Lucille Packard Foundation for Children's Health. What are the domains of the integrated care? We've moved from triple aim to quadruple aim because we decided it was really important to have a measure of the experience of the providers here as well. But top of that list is person, patient, family, caregiver experience, activities of care coordination, and yes, we measure utilization. We measure cost, we measure charge. When we have it, we look at total medical expense, because the way to make an impact on systems is to know what the resources you're using and what the outcomes are. A handoff is a care transition of information from one provider to another. We did some auditing. Presence of information at the time of a subspecialty visit. Families, you guys want that number to be what? 100%. It's 10%, and that's a national statistic. I did, by the way, find one endocrinologist in Phoenix when I gave a grand rounds who said, I'm 66%. So that's interesting, and the reason is he won't give you an appointment until he has all of the records. But for the most part, 10%. And then on a return visit, so those patients that have complex needs that are already in a system, generally it's 0%, because the family just goes from point A to point B, and they assume that information is being transacted from one provider to another. And at some point, somebody's going to say, we don't have to do this every 3 months. Maybe we can go to every 6. Maybe you only have to come back if the PCP and you decide. All right, so for those geeks in the audience, if we have interoperability of EMRs, what is that number going to be? 33%. We did a natural experiment at Children's. We looked at referrals to ourselves. So it wasn't even interoperability. It was literally the same electronic medical records. And 33% of the time, did the receiving subspecialist know why the sending provider was there? So the numbers here, though, aren't the provocative part of this. What's the provocative part of this? Okay, I know families want that to be 100. These are the numbers. The provocative part is this. This is the norm. Healthcare systems, traditionally, for as long as anybody can remember, function on partial or non-information. So they're wired to reinvent the wheel. It puts tremendous pressure on families to be the mediary. And sometimes that's a good thing if the family feels that, yeah, I'm driving this care, but oftentimes, think Miguel, the family just assumes that if I'm going from point A to point B, there's a reason for that. So by the time I get there, they're going to know why I'm there. The opportunity to improve experience and reduce waste and reduce harm and reduce fragmentation is significant. This is the referral form, and notice it doesn't say referral. Most delivery systems, when they hear the term referral, assume that has something to do with approval from an agency or a payer. So I'm not proud of this name, clinician reason for BCH visit. It really is a request for a referral, but there's no way that we're going to override the referral people because they're the ones that are driving the revenue. The good news is this is easy to install in EMRs. So within 6 months, that tool is in 5 different electronic medical records. So essentially, every child that gets referred to Boston Children's Hospital from Boston to the central part of the state comes with this. And on this is reason for referral, What have you done so far that I should either repeat or don't need to repeat? What would you like this relationship to be? Are we going to share the care? Or are we going, is this child so complicated we need to think about a new medical home? And then we measure that data. Here's some real PICS data. A few of the questions, and I'm specifically showing you, this is pre-post data in our Rett syndrome clinic, so that you could see we moved the needle. I know that's a term that you MCH people like, so we're moving the needle. Treated you as a full partner in your child's care, shared important information about your child's health with team members, talked to you about things in your life that cause you stress because of your child's care needs, and explain who's responsible for different parts of your child's care plan. The last one is the one that I want to share with you today that we did something about. In a moment, we're going to take a brief pause. Ketogenic diet is basically the step between, for children that have that have epilepsy, that medications don't control them sufficiently, and it's one step short of having surgery to try to remove or abate the seizure activity. So ketogenic diet, very complex population. So we launched our PICS information, our survey there with the families. But as it was in the field, I said to the team, so what do you think are the biggest problems that you have? And what do you think the families are going to say? And it's really cool. They're not related at all. But the good news is integration, there's no right answer, right? So the nurses thought that the lag for durable medical equipment is the thing that was keeping families awake at night. In fact, it was keeping the nurses awake at night. The families reported that, you're not doing enough to integrate our child back into the school. And I'll remember the moment when we shared it with the team, because most of the time when you show people quality data, the first thing they do is what? It's kind of like a Kubler-Ross moment, right? It's got to be wrong, it can't be me, not going to work. So sort of move into a denial mode. In fact, it took about 10 seconds when the social worker said, oh my, up to now, all I do when I interact with the school is talk about the nutritional aspects. So he was doing his job, but until they administered a PICS to give them a sense of, but your job isn't quite getting at what we really need more broadly. So we created the action grid. Notice that I'm not calling it a care plan. For now, that's a bridge too far. Because we need to get something done. And so the action grid, what needs to happen, in what time frame, who's going to do it, what's the expected outcome, what's the contingency if plan A doesn't work, and what's the follow-up. Every interaction in the epilepsy clinic now ends with an action grid. The family leaves knowing who's in charge of what aspects of care, and we're starting to spread this across subspecialties. So measure of quality, when the phone rings, we pick it up. Families know who's responsive. Remember I told you I was going to show you some outcomes? So here it is. We added no new resources to our complex care neurology population, the Rett clinic. No new resources. We basically did a lot of the blocking and tackling that I just showed you. Mine did the handoffs, used the action grid, and in 1 year, we reduced by 10% costs. We reduced 30-day all-cause readmissions in half, and we reduced the emergency department use, and this piece is key. These integrated care models that are based in subspecialties work with any willing primary care provider. And they all have the families at the design stage. So the care coordination measurement tool, once again, Maternal Child Health Bureau, thank you so very much. This thing was born literally on the back of an envelope in 1992 as I was flying between Salt Lake and Chicago to a medical home meeting. It is now electronic. It is available. It's adaptable. We're using it in all kinds of settings around the U.S. All right, so question I ask my students. True or false? The United States spends more money on healthcare than anybody in the world. So for those of you that said true, you're wrong. And this part is important. Which one is the laser? And the reason you're wrong is that we spend more money on medical care than on health care. The rest of the globe, they actually consider the social service and the health spending in that budget. So the United States, oops, aiming down there is not helpful. So this is the United States spike right here. So yeah, we invest heavily on medical, oftentimes on downstream costs, when much of the rest of the countries that have better outcomes of care invest in health. And there's a message in that for MCH. The good news is we don't have to look internationally. Let's pay attention to our own National Academy of Medicine. Hennepin County Health, here's what a responsive model of integration looks like. Look at the types of care team members. They include pharmacists, for example, folks that are dental service providers, and look at those outcomes. The Community Asthma Initiative in Boston, urban core, Medicaid predominant, and look at the outcomes. We reduced emergency department utilization by 57%, reduced hospitalizations by 80%, reduced missed school days, missed work days, with a team that included home visiting nurses as well. So what can we do right now? Engagement requires trust and relationships. It's one of my dear friends and colleagues, and I know last year's MacQueen Award winner, Christy. And then Eileen Ferlenza, I can't say enough about you, my dear friend. Continued investment in equipping families as informed leaders and navigators, both at a system level and individual level. Educating families has to be a subset of equipping them to be confident. It's an empowerment model. And then implement measurement. It's evidence-based to be able to get the outcomes that we want. So here's a quick challenge for the group. This is the Medicaid core child set. This is the measure around screening for behavioral health needs and then a follow-up plan. The purpose of this exercise is to challenge every single one of you to say, what role would Title V have in that measure? The way this is framed is it's all about the provider, the PCP generally, but think about it. What could Title V do for a program to make sure that the screening is getting done and that the follow-up plan is in place? These are the areas for the National Quality Forum that are their priorities. Medicaid is an amazing resource that is really under threat. We need to protect it, and in fact, I'm going to argue we have to make it even more efficient. And community linkages are critically important. So resources at the National Center for Care Coordination Technical Assistance, interprofessional education. It's not just about docs, it's about the families and everybody that has the privilege of serving them. AMCHP, I love that one. We have to work on this one together. The alignment piece. The alignment piece is where we can make a difference. So what can we do right now? Persist with a compelling and civil and respectful national dialogue. Bring data. Build capacity of families in the workforce. Interprofessional education. Implement measures. Form alliances. Leverage adult priorities. Social determinants of health and behavioral health needs are just as big pain points on the adult side. Let's partner with them in the halls of Congress and at the National Quality Forum at CNS. So here's a challenge to this community. Whenever there is a convening of a state or a federal stakeholders group focused on value-based care delivery, AKA accountable care, Title V needs to be at that meeting. I'd love to have that be a national performance measure for MCH. Be at the table or be lunch. Lots of people are counting on us to get this right. So what's next? Keep calm and carry on and measure value and integrate care. And stay focused. Thank you so very much.
Thank you, Dr. Antonelli, for that inspiring lecture, and congratulations again on winning the John MacQueen Lecture Award. It's so great that we're able to recognize such inspiring and visionary leaders like Dr. Antonelli. So thank you again. And well, good afternoon, everyone. I'm Susan Chacon, and I'm your incoming president. And it's going to be a pleasure for me and an honor to assume the presidency on Tuesday morning, and to also continue our opening session today with this very important conversation in plenary. Today, we are delighted to be joined by several families who represent lived experiences of engaging with maternal and child health systems and programs in their communities. We all know that engaging families in the development of programs, practices, and policies is essential in MCH, and MCH leaders always want to know, how can we do it better? We're about to get some answers from true experts, 4 people who got involved in family health systems as parents, then became engaged as leaders. They are here to share their personal journeys by opening their hearts and even their family photo albums. That sharing starts now.
At the early age of 19, I had my first child, a beautiful baby boy named Tyson. I'd heard that kids don't come with instructions, but I learned very quickly that there was definitely not a manual or even a hotline to call to navigate a very isolated and fragmented system when your child is suddenly fighting for his life at 6 months of age. This was the beginning of our special healthcare needs journey into what became a very complex life.
This is my son, Scott. He was born neurologically unresponsive. He died at 2 weeks old. The day he died, my world came crashing down. We were left with no useful resources from the hospital to cope and continue with our new normal we were suddenly living. I felt alone and like no one got what it was like to have your baby die.
This is Caden, my first child. 30 days after he was born, his mother died, and I was like a fish out of water. I didn't know anything about raising a child. Then during one of his wellness visits, a nurse asked if I knew about home visiting programs. Next thing you know, Caden and I are getting help that I didn't even know existed. And you know what? A lot of struggling parents don't know about the help that they can get as well. So I became a parent representative in the program, and today I specialize in reaching out to families working with dads who could benefit from these programs as well.
My oldest daughter, Lauren, was born prematurely. After a rough start due to immature lungs, my husband and I were told, just take her home and love her. Like any new parent, we had no idea of the challenges we were about to face. But I had a master's in special ed, so we were confident everything would be okay. In our first year, the severity of Lauren's disability became clear, and we started our journey that has become 35 years of navigating complex systems for her care. I still vividly remember a day I stood in my kitchen with the phone receiver in my hand, not knowing who to call. I wondered how families did it with language barriers and other challenges. I didn't want families to feel that awful sense of uncertainty. Helping families became my passion.
Ladies and gentlemen, please welcome Gina Polamoney, Nicole Miller, Anthony Queen, and Christy Blakely.
I first want to thank you for all being here today to listen to our interactive panelist discussion that will give you a glimpse into 4 very unique and personal stories of how we came into each of our individual family leadership roles and the path that led us here today. I do, however, have to disclose that some of you may be very disappointed because we will not have PowerPoint presentations to read from. I am Gina Polamoney, and I have the honor of moderating this panel today. I am from Utah, and am the director of our Family to Family Health Information Center and our Utah Family Voices. I've had the privilege of working with our Title V agency for many, many years and currently serve as a family delegate on the AMCHP Board of Directors. It is with great pleasure that I now turn it over to my fellow panelists to introduce themselves.
Hi, I'm Nicole Miller. I help run the March to Dime's online support site, Share Your Story, and I'm from Elkridge, Maryland.
I'm Anthony Queen from Grand Rapids, Michigan. I'm a parent rep for too many different organizations, but I'm glad to be here.
I'm Christy Blakely, and I'm currently working with NICHQ, National Initiative for Child Health Quality, around family leadership in one of their early comprehensive childhood systems grants, and I'm former Family Voices in Colorado.
Thank you. We're all going to take a moment to talk about our journeys and open up our hearts. I'll start off with my story. The best way to do that is to kind of give you a quick timeline, and then we'll get into some of our leadership roles afterwards. I was that 19-year-old person that had the baby. Tyson came a week early due to an emergency C-section. He was very low birth weight, not quite sure why, but induced and heart stop. So all of a sudden, I had this little 4-pound, 11-ounce bouncing baby boy. Though I will disclose, the first time I seen him, I'm like, oh, he's very long. He looks like E.T. And the nurse was horrified. But after a week of being in the hospital, we were able to go home. The first 6 months was such a challenge because he was born in the middle of summer, and he kept getting cold after cold, and some of those led to pneumonia. We were hospitalized. Upon each discharge, we noticed that his gross and fine motor skills had declined significantly, so started running lots of tests, genetic tests, lab work, family history. I can even remember at one point, I did not know why they asked this question, asked me and my husband if we were related. And I thought, is that because we're from Utah? I didn't realize there was a genetics component to that question. He was about 6.5 months old, though, when he got one of the significant colds, took him to our pediatrician. We had a medical home before the words medical home were prominent. And we were life-flighted immediately up to our children's hospital. We only lived across the valley. By the time I drove up there, they had him fully ventilated, and that began to where I would become a mom of a child with special health care needs. He was put in the isolation unit. We spent months upon months in the PICU with no answers. And I remember having one of the docs very caringly saying, we may never get you an answer. There's just sometimes you don't get answers. So when he stabilized, and he stabilized by getting a trach, and being fully ventilator dependent, we started looking at what's next. This was before some of the Medicaid waivers. This was before some of the home and community-based services that we have now. And so our only option that they gave us was to admit him into a skilled nursing facility. And, yes, I can be very quiet. My Utah team probably doesn't think so, but until it comes to your kids. And then it was like, no, this is my baby. I don't want him to become a bed number. He needs the love of his mom to thrive, no matter what's going on. So we thought we would just head through that journey, and got home, realized that we weren't Medicaid eligible, and this went before the ACA, so we were uninsurable because we had maxed out every insurance benefit we had at that point. But life became normal for us in that routine. We did watch out the window and see all the other families going places, and we were very much isolated in our own world, but it became comfortable. We bought a house next door to my mom, which was great, and when caller ID come out, I realized that it's a bad and a good thing, because when I was calling, she knew I was calling. And when she wouldn't answer, I would say, I just seen you pull up in your driveway. But that part is the family support. We would have never been able to pull it off without the family support. So many of the things that I was learning on my own. My only connection to other families, unfortunately, was through the annual Jerry Lewis Telethon, because so many of those kids on there was what I identified with, even though we didn't have a reason of why Tyson was like this with his declining health. So my husband got a new job, and we got new insurance benefits. He worked graveyards because I was able to find a job through our classified ads, and the job description was seeking a parent of a child with disabilities. And I thought, wow, there is such a thing. Went and applied, got a clerical job at our Parent Training and Information Center. And I then learned, and this was by the time way past 3, I learned that there were things like IDEA, IEPs, CSHCN. Had no clue, and learned all of that. So started, because now I have this tribe or village behind me at the Parent Center saying, this is what we're going to do. Tyson deserves this. Well, 4 years later, we had no answers still. I had my next child, and within 36 months, I had 3 children, plus Tyson. And did I mention to tell you how isolated we were? Life, but we were thriving. We got to the point where, every year my husband would go on an annual deer hunting trip with his family. That was his respite. Going to work, believe it or not, was my respite, because I had other moms. Jeff came home the last year, or in the year that my daughter was born, the 4th child, finally a baby girl that I could dress up in pinks and purples and such. And within 3 months, 3 months was the deer hunting season. My husband come home not feeling real well, and within 2 weeks he passed away. I was a widow at 26 years old with my oldest on life support. We had a mini PICU in our front room, as well as 3 younger children, one being 3 months old, and then my middle son, Brighton, showing significant developmental delays. That's when I found out the system's failures, is that when you get survivor's benefits, you make too much to qualify for Medicaid, even though you have a child that requires all of the equipment, the support, and services and such. So I will just say, after Jeff died, my 5-year-old died 3 years later, and then another 10 years later, Tyson passed away. But I say that he was one of the children that said, take him home, love him. We figured a couple of years at the most, and he did it his way. He waited till he turned 17. So with this, I'm going to turn it over to Nicole to talk about her story.
All right, I'm going to start by sharing a little bit of my story with you. My husband and I had what we thought was another perfect pregnancy after having no complications the birth of my first son. It was the day after my son's 3rd birthday, and 2 days before I was 37 weeks, that I stopped feeling fetal movement. At the hospital, they found a heartbeat. They induced me out of error of caution. My son was born at exactly 37 weeks, comatose, and had to be revived. It was determined throughout his short life that he had none of the primitive reflexes needed to survive. It was also soon determined that the neurotransmitters of his brain did not work. Basically, Scott was brain dead. Decisions were made, and he died at exactly 14 days old. I suddenly had my whole life turned upside down with no way of fixing it. I was sad, angry, and very depressed. I was lost emotionally and mentally. I had a great support system, a family of friends, the best anyone could ask for during that time, and I had a grief counselor we had found. but it wasn't enough. I felt like no one had got it. I was feeling very alone. It was 8 months after my son died that I started learning about the March of Dimes. While exploring their website, I came across a link for Share Your Story. And during that time, it was the first time that I felt a little bit of hope, a little bit of excitement for the first time since everything had happened with my son. While exploring their website, I came across the link for Share Your Story. I started looking around their site, and I found people like me. People whose lives were turned totally upside down, people whose baby had died, people who got it. I joined the site and started posting in their forum section on loss and grief. Immediately, I started getting that support that I needed, that I was craving. People through their comments were being uplifting, comforting, and sharing their similar experiences, thoughts, and emotions. Sometimes just sharing that virtual hug when there were no words. The site quickly became my lifeline on the tough days. The people on the site become an important part of my life, like a second family. A year into being on Share, they asked me to take on a role as one of their moderators for the site, and I became a part of the welcoming committee, and I've been on Share ever since. Share has made a difference in many people's lives. I know personally there were a few times when I thought I was going a little bit crazy with some of the thoughts and emotions I was having. There were thoughts that I felt that I couldn't share with my family or friends, thinking they were just going to find me finally going off to the deep end, and I didn't want to share it with them. And so I would go on Share, though, and post these same thoughts and emotions, and I would get the me too. And that was really important to me, to know that somebody else was feeling that. Because of this, I feel like I was able to really, truly start to heal and truly move on with my life. I don't know if I would be where I am today without the support of the people on Share. I would also like to share 2 comments from 2 people I've made friends with on Share. This one is from my friend Erin. She said, in March 2007, my life came to a screeching halt when my sons were born prematurely and passed just at 22 weeks. Other than recalling an old high school friend's classmate's loss, I didn't know anyone I could turn to for support. A few months post-loss, I stumbled on the Share. Here was a community of mom and dads who got it, who understood how I felt, who could let me rail against life for being so unfair without judgment. I finally had found a home, a safe place where I could grieve the way I needed to. I credit the parents of Share for walking hand in hand with me and helping me through my darkest days. Nearly 11 years later, although Share is still my lifeline on the rough days, it has become a place where I can now pay it forward and support to other moms and dads who are walking in the same shoes. So even though it's been 11 years for her, she is still very active on Share. And then this one is from Brandy. Share is my safe place, where my grief can be sated, my hope is renewed, and my feelings are always validated, if not echoed. It is where I have found my dearest and truest friends, even though I'm lucky to see them in person just once a year. It's a community that allows you your darkest moments, but rescues you before you're stuck in that abyss. Contributing to a forum where my personal narrative can inspire and comfort others has given me more peace in my grief than I can ever begin to explain. And this is what's special about Share. I feel like Share, it's real. It's real people who have been there, experienced the worst imaginable thing, your baby dying, your baby fighting for his or her life. It's people sharing their stories and asking questions with one another through blogs and forums. It's people sharing their raw emotions and getting the support needed to get through one more day. It's people who get that there are times you don't want to hear the inspirational feel-good quotes, things happen for a reason. The people on Share, as I continue to say, they just get it. And this is why it works. And because this site is run by volunteers who have been in the trenches and get it. We speak from experience, and we can offer support, understanding, and healing in a non-judgmental way. Because it's run by volunteers, it gives you a sense of ownership. We have a say in how it's run. Therefore, we can say this is what people need. We know because we've been through it. We have committees that run different sections of the site. When we see something that needs to be addressed, we contact each other and address it. I am on the welcoming committee. We make new members feel welcome. That when someone posts, that we make sure there is someone commenting so they know their story is being heard, that it's being read. Many people read Share daily, but they are reading and getting the support without letting the people posting know their stories are being read. My committee's job is to make sure they know that. If we see a post that we know other Share members have experience with, we'll reach out to them and ask them to log on and read and comment to that post. The site continues to work and grow because those of us who help run SHARE, we want to see SHARE continue to grow. We know how much that support meant to us, and we want to pay it forward to others going through the same thing. I can say that the people on SHARE have become my friends, and that I have formed a special bond with them. Just the picture there, these are some of my friends that I've made, meeting them a couple times a year. To be able to say that, I think, is very powerful, because there aren't many online places where you can go on publicly and feel like you're being heard yet not being judged. Instead of judgment, you are getting lifted up, you are getting empowered to continue on this journey you are forced to take, and you are getting the strength to take that next step in your healing. Thank you.
Thank you, Nicole. Thanks. Anthony.
Yeah, okay. Anthony, 30 days after my son was born, his mother passed away. And you might not know me, but don't much scare me, but this scared me to death. This was going to be his first time that I was going to have him for the weekend, and his mom passed away, and all of a sudden, I was there with my son, having to basically raise him by myself. At one of his wellness visits, a nurse came up to me and asked me if I was interested in home visiting. The nurse came up to me because she said I had an inviting face and an inviting laugh. But I encourage you who work out in the field to maybe get out of your comfort zone and include dads in your invitations. Dads should not be something special that needs to be done. It should be part of the everyday fabric of an organization. There should never be a time when you as an organization have to tell a dad to insert dad where you see moms, that I was told over and over again. I had home visiting for 2 years and was asked by the organization if I was interested in becoming a parent representative. Little did I know that this would change my life. What I noticed right away was that all the material was geared towards women. Going out to the organization, there were no pictures of fathers on the walls. There was just an overall lack of positive imagery of fathers. But they wanted fathers to be involved. I encourage those who go out in the field to get both sides of the story. I cannot tell you of the number of times I spoke to workers, and they had been working with their family for quite some time and hadn't met the dad. By the time they finally did meet the dad, the view of the father was tainted because all they heard was negative from the young lady. But I encourage you to get the full story so that you might not be tainted and form your own opinion of the dad. And sometimes I might take special meetings, anything that can be one-on-one, so you can get the dad's or the boyfriend's side of the story. Under the Great Start Collaborative umbrella, I started working with strong fathers and began the initiative of the inclusion of fathers in every aspect of the home visiting continuum. I keep the mentality to meet dads where they are. I've come to understand that you can't have a blanket approach to engage dads. It is up to me and up to you to engage and empower them. One of the most important things that you have to recognize is the stigma associated with having a state worker come to a house. Many of the minority dads you are going to speak with, and you are going to speak with them, associate a state worker with something with bad memories. So acknowledge that in the beginning, and it helped me to break down that barrier in the first 5 minutes. Many times I have attended meetings and conferences through the home visiting continuum and noticed that there weren't many dads involved, and the material that I was given would all be about moms with a paragraph for dads. That 94% of those in attendance at these conferences were women, which is great for bathroom breaks for me. I can just zip in and out while you guys have to line the wall and wait and wait. But that's bad for inclusion. This is great for my bladder, but terrible for inclusion. It is my hope that after today, you would take the mantle of the inclusion of dads in your programs. Through repetition at many LLG and state meetings, and that means when I was raising my hand at the meetings, they knew it was coming out of my mouth. Why isn't dads included in the material? There has been an acknowledgement that dads need to be positively recognized and that all the material going forward would be with the inclusion of dads. It's important that I see people like me as decision makers, not just out in the field, but when you're making those decisions, because what sounds good up there in the ivory tower doesn't work on the bottom floor. Finally, there's outreach. If and when you are ready to engage dad, there needs to be a recruitment set up to entice males to be part of the process. Number one, food. I've never invited a father to a function and told them there was food and that they didn't show up. So that's number one. Second is sporting events, whether they're playing or just watching. Third, and this is the great pipeline, there are the barbershops starting in each and every neighborhood. That is a great way to connect with dads. If you get an acceptance from the barbers, the battle is halfway won. Let the barber know why these programs can help families and dads. The best form of advertisement, of course, is word of mouth. Provide stipends and honorariums, gas and gift cards. There is daycare and diapers to pay for. This helps with those expenses and shows how you value dad's input. And you covered two of the main things that we males look for, money and food. The one thing I want you to take home, if there was any one thing, it would be the insanity advertising. And that's when you put the same money into the same way and advertising the same thing, but expecting different results. I call that insanity advertising. You need to change your ways and think outside the box. Finally, one of the things I want to leave you with is what Frederick Douglass said: it is easier to build strong children than to repair broken men. Thank you. And finally, I'm going to hand it off to Christy.
Hi. We had our first of two daughters, and she was 7.5 weeks early. Data, she was 4 pounds, 10 ounces, bigger actually than I was at birth. And we thought, this is great, until she crashed about 24 hours in. She had hyaline membrane disease, which doesn't exist anymore, really, because of a cow surfactant that is now a byproduct of a cow. Anyway, I won't go into the medical stuff, but Lauren was in the NICU for a month, and we brought her home on a tube that went into her tummy, and we were trained to put that tube into her stomach and make sure it wasn't in the lungs by shooting a little air in. And we were too young and stupid to know that that was a pretty scary thing to be doing, and that actually in our world today is a skilled care that shouldn't be and invasive. So that was our new normal. We went home with this child who ate every 2 hours, and it took us about an hour to feed her. And my husband was in law school, and so he took 2 of the night times because he was up anyway studying. And we began having things like wheelchairs in our house. The first thing Lauren did with that wheelchair that's in that picture is lock her sister in a bathroom with the door went the back one. I heard, "Mommy." And Lauren just laughed and laughed, thought that was the best thing ever. So those who say you have civil rivalry when you have a child with special needs, no, you do. It just looks different. She runs over the Barbie and then laughs. So Lauren attended public school and was fully integrated. There were times where professionals didn't see what we saw in Lauren, but with the use of communication devices like this one, the Liberator, which doesn't exist anymore, but it had a ticker tape so that everything was printed out. So I actually have a sampling of Lauren's work as she went through school, which was pretty cool since she didn't write. But she's had a pretty amazing life. She's gotten to carry the Olympic torch. She just tried out for America's Got Talent with a dance group out of Colorado. She's been to Vegas more times than I ever want to go. She's just had a pretty amazing life. But along the way, we lived what that picture was of all of that therapists and school and all of that whole kind of mess. It looked like spaghetti. We lived that. And today, as Lauren is 35, going on 36, and in a relationship with a gentleman, she lives at home in her own home and has an amazing sister that has given her 2 nephews that she loves. Lauren continues to use her communication device, and technology is her access out. But along the way, I found my voice by finding that a social worker told me very early, you are your child's best advocate. And so when I entered her in school, when I entered any therapy, we talked about what we saw for Lauren and what our goals for Lauren were, and that was to live independently and to have the best life she possibly could. I worked for Medicaid at a time in Colorado. I actually had state and parent on the same card. It was a Robert Wood Johnson grant, and I worked to train what we now call nurse navigators or nurse coordinators. And in the process of doing that, I was able to find my niche in Family Voices and took over the Family Voices in Colorado. And in doing that, I was able to grow family navigation. I was able to engage families and work on family leadership. I remember very clearly the very first conference that I ever went to. Lauren has never slept through the night, and so my presentation the next morning was something like, I kind of at 2 a.m. wanted to call the desk and ask if anybody needed to be flipped during the night, because I was so used to getting up and turning somebody or, turning off a machine or whatever, and I didn't get to do that, and nobody needed that in the hotel that night. Darn. Anyway, Lauren looks like a success story. She lives on her own with a significant other, but we continue to be challenged. We have to work through things like HUD. We have to learn and navigate new systems. Dr. Antonelli talked about medical homelessness, and Lauren at 35 isn't really 100% welcome in the Children's Hospital, and yet at 88 pounds and having a nutritional issue that just came up this last week, we need somebody that can help us nutritionally, and yet I don't have that. So in many ways, it looks like a success story, but it's not always a success story. Even for those of us that look like we have it all together, we're all in this together, and it does take a village to raise these kids. And we work together, and we have an amazing family, but we also have an amazing support system. And oftentimes when we see families, we are enjoying the fact that we are in that sorority or fraternity that we never wanted to get into, but we're in it. We don't get to get out of it. We're always going to be parents, whether they're 35 or 55 or whatever. Lauren and Mitch are experiencing good health right now, and we're very blessed with that.
Thank you, Christy. So you've heard some similar themes and heard from each one of us. I want to jump in and say about the training, because it's one thing to fall into family leadership, because as Christy just said, we've all been told, you are your child's best advocate, and if you don't do it, who will? But along with that comes, how do you communicate effectively? How do you go up to the hill? How do you tell your story that, it makes a huge impact? So for me, I was lucky enough to be early on when it was starting, introduced to Family Voices, which was a national network of families, grassroots families across the nation that were all finding the same things I did, is that you're not qualified for Medicaid, even with having barely any income, and insurance wouldn't pay for the therapies that needed. So I got to have that family leadership training every single year for many years from Family Voices, and MCH as well. I have to thank MCH. I was able to go through the MCH PHLI, which is the oh, wow, I just forgot. Everybody should know that. Public Health Leadership Institute. And so I, as a family member, am very fortunate that I had some of the leaders and mentors that I did. So I want to throw that out to you all to ask if you had any formal or informal training.
Well, I think for me, I stumbled on Share and was happy to find it, and then they're contacting me a year later going, hey, this is volunteer run, we need your help. And I was like, how do I qualify? They're like, just keep doing what you're doing. And we try to do conference calls, about once a year, or if they're able to, we try to meet up and do strategic meetings. We're actually going to be doing one in May in DC, where just the key volunteers on the site will get together and just discuss how can we make share better, what do we need to tweak, meet the needs of technology and what's going on today. So,
I would say for myself, my son isn't a special needs kid, except for he has me as a dad. But what's rare and what the public needs to know is that I'm not alone. I'm not an African-American dad who's taking care of his son. I'm not the only one in America. And sometimes when I go to these organizations, different places, they make you feel like that. And I want to break down and kick down that stereotype that we as African-American men, there's a lot of us who take care of their kids.
Working, that's true. Working with NICHQ and doing collaboratives where we invite families to be a part of things, I'm always asked, how do we find the families? And I think, the families are out there, and they do come along. And having training or having some information about how do we work with them is critical. But another piece that's really critical is one that Anthony hit on, and that is reimbursement. So that we're not just expecting them to come out of the goodness of their heart or pay for their parking or whatever, but really engaging them at a level that they're not the only person not paid at the table. And that's a really hard one. It's a hard one because we often think of the family after. And I liken it to a dinner party. You don't invite somebody to your dinner party and tell them the time of when you're really going to sit down to dinner. You invite them like everybody else at the beginning, and we often have our ducks in a row, so to speak, before we invite the family in. Well, after that, the budget's already done too. And so we're inviting the family in. They're never going to feel a part of the project because it's too late. We've already had hors d'oeuvres, and we've had at least one adult beverage, and we're pretty happy, And so then the family comes in, and it's like, well, we're really, where we feel we need to have something for them to do, we don't. They need to just be at the table as themselves.
Thank you, Christy. And I know for us, along the way, because as you're trying to figure out the systems, I knew healthcare policy and Medicaid inside and out. And I fortunately also had a wonderful CSHCN director when I first started that said, as we go forth and try to make systems change for all children and youth with special healthcare needs, I want you to be along on the ride. And so that was not inviting me. And because sometimes I was invited just to the cleanup, not even to the dinner. So that made a huge difference. And when we talk about why do you still stay involved, for me, of course, it's because there's a legacy for 2 children that did not get to grow into into adulthood. And for the 3 siblings that are still with me that had to go through all those hard times. Because as Christy said, we paint this picture. It was not easy, and it's still not easy. But we live through the pain and put it towards good use. And so what keeps you involved?
I think what keeps me involved is just that I know what it felt. I mean, I was having the perfect pregnancy, was going to have another little boy running around the house, and life was going to be grand. And that was ripped out from under me in the snap of a finger. And so my whole world was turned upside down. As someone who plans and makes everything better, I'm the classic middle child, my brothers will tell you. It was like, what now? I couldn't fix it. And so I was left with nothing. And until I found Share, I didn't know what to do. I didn't know how to go about fixing it. And then I found these people who got it, they understood it, and they were telling me it's going to be okay. And that's why I stick around, because if I can go on Share and there's a new mom or dad or grandmother or aunt posting saying, hey, this just happened, what now? I can tell them that it is going to be okay. As long as you can get to that next minute, it's going to be okay, because that's where I was at one time. It wasn't even getting to the next hour. It was literally getting to the next minute for me.
What keeps me around is there's too many families that can benefit from these programs, and it's just the stigma that needs to be knocked down. And so that's what I'm trying to do, and that's what keeps me motivated, is seeing these families receive the same assistance that I received. Because like I said, I was first-time kid, didn't know anything about raising a kid, really didn't want to know anything about raising a kid, but when it's thrust upon you, you do what you have to do. And I know there's tons of families out there who could benefit from these same programs.
I mean, coming into this as a master's in special ed, and I should have known a whole lot. Standing there in that kitchen that one day with a receiver going, I don't know who to call. And yet, I felt like I was the lucky one. We didn't get Medicaid yet. There wasn't such a thing, and we didn't qualify. But I knew enough to read the insurance plan, and I knew enough. I mean, there were things that I could do and I could figure out, and I just couldn't help but think, well, what about those families that, either it broke up the family, as Dr. Antonelli talked about, or they don't speak this language, or they, I couldn't not help those families. And navigation hasn't gotten any easier. We make it really tough. Even in the state, we change the name when you cross the county line often, or, the same program isn't run in the same way or called the same thing in the next town over. And it just is really difficult. And I didn't want families to feel alone. And that was one of the words I heard this morning in a mom presenting. She just felt so alone.
Thank you. Thinking even about, and I said it's still hard to this day, I have to, though, give credit to all the parents and moms and dads that came before us, because we have so much more. Tyson would have been 32 this year, and so just the huge differences, and it's because of all of you and working with us and making a better life. But there are still some things out there that I think are, oh my gosh, how many times do we have to say it? I was counseled, or I should say my husband and I were counseled to get a divorce because we could probably qualify for SSI at that point.
Yeah, so were we.
I think, I know how it affected me, and I'm thinking I had to make a choice of splitting up my family or getting the healthcare services and funding. Well, of course, I was going to do whatever it took for my child. And I've also been questioned because, with my story, many people, I have to say, have used me as a token, and I want to say, no, absolutely not. For us, unfortunately, having a child pass away is not the worst. It's being a mom and seeing how they need things and they're suffering, and there's not a dang thing you can do about it because you have the systems and red tape. So hopefully at some point, healthcare will become a right.
No, in one of our preparing calls, one of you all said something that really hit me, and that is, we don't have a word for someone that loses a child. We have, you're a widow or widower when you lose a partner, but you're not anything when you lose a child. And yet there's that huge amount of grieving, all the hopes and the dreams. I mean, I know I grieved Lauren in how she is versus, when she didn't have a voice, and when we worked on access for her. There was grieving because I thought, oh, she's never going to have a personality. Boy, was I wrong. I texted her while I was waiting over here and said, I'm getting nervous, because we were waiting so long. I was getting nervous. And she said, just be Christy Blakely. Thanks, Lauren. I appreciate that.
But to build on what you said, it is tough being a lost mom. There is no word, and so sometimes people see your life as I only have an only child, and I have to sometimes choose the situation I'm in, whether I say I have another kid or not, because I sometimes feel like I'm throwing that live grenade in the middle of the room. Like, am I going to set them off? Am I going to, people expect sympathy. One of the things before I started homeschooling, because I'm that crazy mom who now homeschools, is I was at a PTA meeting, and people were going around the room, oh, I have twins, oh, I have this, and I'm like, do I just say I have a kindergarten? Do I bring up Scott? But I felt like if I said that I have little angel Scott, that people were going to, I wasn't going to expect sympathy, and like I was trying to make a mountain out of a molehill, so I kept my mouth shut, and I always feel bad when I do that. So it is tough navigating that, especially when I have a now 8-year-old who, he talks about his brother more and stuff.
Right.
So.
And I think as we have gone along and watched all of the systems changes and such, I think back to even when CHIP was passed. I look around this room, and many of us were there with our professional partners to get such significant pieces of legislation passed, because we know how our families are affected. And at the same time, CHIP wasn't something that would ever help my family, but because of the healthcare navigation policy and all of that, we're very effective in many systems changes that go on within the states and at the nation. And I just want to share real quick, even with our Family to Family Health Information Center funding that we have to panic about every 2 years. Thankfully, just recently, we heard that it was funded and even expanded to the territories and Native Americans. So thank you, MCH community, for helping us advocate for that.
I think especially in the work that I've done with NITQ and the collaboratives, I've watched significant change when families sit at the table. The dialogue changes, the demeanor changes, and the passion is there. Not that professionals don't have passion, but the parents are bringing a passion, kind of like Justin Dart said, stay involved in politics because it will mean your life. I didn't do that well. Stay in politics, something about your life. And for families, this is our passion because this is our life as well. And I think as I see the tables and how people do, I'm seeing change. I'm seeing systems change almost every day with these families that are in the system saying, wait a minute, you're going this way with this wonderful project, but I see a problem over here. And for us to back up and say, oh, okay, in fact, that's something we should take care of before we go over and do this next thing. So I think, the dynamic of the family is critical.
I think the touch on what you're saying is something that really resonated with me when we were on a phone call last week together, was when you were sitting there and saying how, we don't have a choice in this. Like, people can change careers. This is our career. We don't get to change it. And it brings me to think, referring back to Anthony, I think it's great we have a dad here who's so involved, because I know my husband looks at everything I do for the March of Dimes in here as this is my role, my thing. Like, he'll support me, he does the March of Dimes walk, but he looks at it as my thing because there's no space for him. Like, he doesn't feel like there's an opportunity for him to do it. And so I think it's great that we have Anthony here saying that we need to make more avenues for dads to be able to have a say, because they're supposed to be the strong, tough ones who just soldier on and be the provider for the family.
Amen, sister.
Yeah. Yeah, I agree. And I think sometimes dads and moms don't always grieve or function in the same way. About the time I'm looking at husband and saying, I just am thinking we're not doing as great, and he'd be like, oh, I thought we were doing really well. So it always seemed like when I was down on something going on, he was handling it, and there was this dance that went on that we didn't even plan, but somehow we did it.
Definitely. I know my husband, he grieves so differently. We went to counseling together, which was the best thing we ever did, because we saw how each other was grieving. He angry, which I think is a common thing for men. Men, show it through their anger. And he would shut down. I mean, he basically just shut down from the work and home on the iPad, and that was it. So, and I wanted to talk about it. So I think it's important to get the men's perspective, the dad, their role. And
yeah. I want to put a challenge out there to those of you that are involved in gathering meetings, et cetera. If you don't have a parent at the table, please pull up a chair and get a parent at the table, because I really think that parents and the power of parents will be your sustainability plan, and really will continue to make change. And I've watched one epilepsy collaborative with MacQueen that these parents, every single one of them went and changed laws in their state to help their kids with epilepsy. And there's just a power that goes along with these families. So please, that's my challenge to you all.
So I think if you will all give a lasting impression and a final statement.
I guess we'll start with me.
We'll start with
All right.
you.
I want to leave you with this one favorite quote of mine that I actually, the day I found it, I was very excited and instantly knew I had to share it with my Share family. I'll share your story, so I posted it on my blog. One day, someone is going to hug you so hard that all of your broken pieces are going to stick back together. And this is what Share does, even when it's just a virtual hug. It's real people who get it and telling you that it's going to be okay. They are giving you that little bit of hope back that you've lost.
Mine would be, as I said previously, mine would just be the insanity advertising. If you're going to keep putting monies in the same things, you're going to keep getting the same results. So try switching up for 2018.
I said mine. I challenged everybody. You can clap, though.
So I'll build off of that then, Christy. That challenge is there and want to give everybody a resource for that as well. There's many parents that want to have their voice heard, and we need to make sure that we have them supported. And so there is a parent organization in every state, especially a family-to-family health information center that works on healthcare initiatives. And you know, even if you can connect them, because that was one of, as we've all said, we just wanted to connect somebody that could understand sometimes our tears or our dark humor or whatever, and not have to explain that. And so getting them connected and building on their leadership skills, you have a lot of untapped resources in dads, in moms, and I will throw in their siblings and grandparents all have something to share.
Yes.
Yes, think beyond. Yes.
And again, thank you for being a part of our discussion today, and hope that you can all take away something about, of course, how wonderful families, consumers, and youth voice. Oh,
Yes,
my kids
yes.
would kill me. Youth voice. So thank you.
Yep. Yay. Yep.
Wow, thank you so much for that outstanding plenary and for all of our panelists, and to Gina for your moderator. Family engagement is vital to our MCH and Title V programs to ensure the programs and services we provide are meeting the needs of our families across all of the states and territories. I hope through this panel discussion you have gained key insights into the importance of considering the appropriate level of engaging our consumers. Such sessions such as this provide us an opportunity to assess our systems and examine new approaches with families, both familiar and new. We are now going to wrap up our opening day by recognizing an upcoming and an emerging MCH leader. Our thanks to our long-term sponsor, Alan Stam and Go Beyond, who created the Emerging MCH Graduate Student Scholarship for just this purpose. Please welcome Lisa Olds of Go Beyond to the stage to present the Emerging MCH Graduate Student Scholarship winner.
Thank you very much. How inspiring, right? I mean, the heroes over here, our parents, our families, everyone out doing the work in MCH. It's been truly uplifting for me to be here, and you can tell I'm not Alan Stam, right? So good afternoon, and Go AMCHP 2018. It certainly has been a pleasure for our organization to again present the Go Beyond MCH Graduate Student Scholarship. This is our 7th presentation, so it's been a little bit of a history for us. Go Beyond MCH has just finished celebrating our 20th year, providing innovative information, technology, and program services to MCH family, fatherhood, go Anthony, and other community programs. It is through this work that we embraced the need to help our most promising future MCH stars as they transition from their education to leadership experience. Thus began the tradition 7 years ago of presenting this scholarship in the amount of $3,500 each year at the AMCHP conference. All of our scholars over the years have been exceptional, dedicated, passionate people, and all have gone on to greater things and accomplishments. And our scholar this year, Ogogo Igodan, is no exception. Besides achieving academic excellence, her references were all returned in the top category of outstanding in every area: character, advocacy, initiative, community affairs, leadership, maturity, oral communication skills. Oh, gosh, really? No. I had the honor of actually spending some time with her today, and she is just fantastic. Ogogo is a second-year Master of Public Health student in the Maternal and Child Health program at the George Washington University. She graduated from The Ohio State University in 2011 with a BA in International Studies and minors in French and Women's Studies. Prior to graduate school, Ogogo worked as a program analyst for the President's Malaria Initiative at the U.S. Agency for International Development in Washington, D.C., and in this role, she provided programmatic, technical, and operational support to the Malaria and Pregnancy Technical Working Group, the Malaria Vaccine Development Program, and the Commodities Procurement and Supply Chain Team. You haven't done enough. She has work experience in Uganda, Burundi, Tanzania, and the Democratic Republic of Congo. In addition to her work in global health, Ogogo is deeply passionate about eliminating health disparities in the U.S. She has served as a teen parenting program volunteer at Young Lives DC, an HIV/AIDS peer educator, and a women, infants, and children program volunteer at Mary's Center for Maternal and Child Care. After graduate school, Ogogo hopes to work as a public health advisor and volunteer as a birth doula at Community of Hope's Family Health and Birth Center. We had a really nice discussion about that too. Yeah. So Ogogo's long-term career goal is to be a senior maternal and child health advisor, working to improve the health of women and children and families both domestically and internationally. And I have no doubt that Ogogo will achieve her goal. Why don't you come on up and say hi? Give you your award. Okay, so here's what we're gonna do, because we're gonna practice this like live, right? Okay, so very important part of the Go Beyond MCH Graduate Student Scholarship Award is to give the scholar the opportunity to attend AMCHP conference, where she can begin to engage and build a network of fellow colleagues. And we hope you're going to take the opportunity to meet Ogogo through the rest of this conference and make her feel welcome. I'm sure you will, so let me go ahead and give you your plaque. Wow. Yeah, the money's for me. No, kidding. There you go. Thank so you lovely. So that's beautiful. And then this is just a little pocket change. Oh, thank you. So go ahead and say some words. Okay.
Wow, wow, this is big. Thank you so much for the kind words, Lisa. I'm truly grateful to receive the Go Beyond Me MCH Graduate Student Scholarship. A very special thanks to Go Beyond MCH and the MCHP Scholarship Committee for selecting me as the 2018 recipient. I look forward to working towards a more equitable healthcare system and improving the lives of women and children in the U.S. and abroad. Thank you again.
Wow, we made it through. What a great session. Good afternoon, everybody. I'm Lori Freeman, AMCHP CEO, and it's been my pleasure to be here today and to wrap up this session with some general housekeeping remarks. First, I'd like to add my deep admiration and appreciation for our opening entertainment, the Arlington Children's Choir. And I'd like to really thank Gina and Nicole and Anthony and Christy for a fabulous plenary session. And if that isn't enough, we have Agogo, who has an amazing career ahead of her, and we wish her all the luck in the world. I also want to acknowledge our sponsors for the conference and thank them sincerely for their continued support of AMCHP. The Women's Preventive Services Initiative is our silver level sponsor. City Match Co-Effective, the Society of Public Health Education, and the National Coalition of STD Directors, along with the CDC, are our bronze level sponsors. The Adolescent Health Initiative is our media sponsor. And I'd also like to also recognize that City Match and the Women's Preventive Health Services Initiative have provided long-term support to AMCHP, so thank you very much to both of those organizations. I hope you'll take some time to get to know these organizations while you're here in the exhibit hall. They not only support AMCHP in this conference, but they support the field of maternal and child health and the very work that you do every day as MCH professionals. As a preview to tomorrow's plenary session, which is caring for families during periods of severe crisis, I'm now very proud to present to you a brief video from the Puerto Rico youth who will give their very personal experiences related to the hurricane.
On September 20th, 2017, Puerto Rico felt Hurricane Maria's destructive force. Unexpected challenging events and traumatic experiences affected all Puerto Ricans, but especially us, youth, during the event and afterwards. After the hurricane, we needed a way to express ourselves and let out all the feelings and sentiments that came up along the way.
The Puerto Rico Title V Adolescent Health Program developed a strategy to provide a safe and secure space where we could ventilate our feelings and work towards healing.
To start, a grounding exercise was done to help us connect with our body and mind, and prepare ourselves to share what we went through.
Then, we each reflected and wrote down our thoughts, first impressions, and overall feelings. We were also asked to mention what we learned from the experience and what positive things we could recall. This led us to exercise empathy and connect with others, developing messages of hope.
These messages convey the resiliency, solidarity, and hope of the youth in Puerto Rico.
More than 500 of our youth aged from 11 to 24 years in the Youth Health Promoters Project and Youth Advisory Council from all over the island created their messages and shared them in multiple ways.
Durante el huracán María me sentí triste, ansiosa y preocupada por lo que le pudiera pasar a mi familia y a mi hogar.
Esta experiencia fue un poco impactante al ver cómo mi familia se trepaba al techo por miedo de ahogarse.
Y lo importante es que estamos vivos.
Recuerdo, todo obra para bien, así que
pa'lante boricua.
Es todos unidos, en paz, podemos lograr la estabilidad de Puerto Rico.
Me sentí en el huracán ansioso, nervioso y con poco miedo. Pero cuando el huracán estaba soplando, estaba viendo el océano y sintiendo el viento fresquito. Y en la estación me relajé un poquito, aunque todavía preocupado.
En estos momentos nos encontramos en un proceso de recuperación, donde nuestra fortaleza y perseverancia tiene que salir a flor de piel, donde los momentos que hemos pasado los tenemos que utilizar como motor de esperanza, como ese motor que nos va a ayudar a ser mejores personas y nos va a ayudar a estar presentes en la vida de los demás. Esa es la palabra, estar presente. Estar presente es para apoyar, para ayudar y para hacer de nuestro vecino nuestro amigo.
Me sentía inseguro, pues porque no sabía nada de mi familia, estábamos incomunicados. Y el miedo a que los perdiera, pues me inundó aquel día. A la gente que sufrió ese día, que lo perdieron todo, que tuvieron que empezar desde cero, les digo que no están solos. Y ese día nos dimos cuenta que a quienes tenemos realmente es a nuestros hermanos, a nuestros vecinos. Tenemos al boricua, que es un guerrero incansable, como diría Virgilio Dávila, ese día aprendimos a amar a nuestra tierra. Y a pesar de que quedó desolada, vamos a volver a florecer.
El 20 de septiembre, el huracán María azotó
fuertemente
nuestra isla. Al momento del huracán sentí
tristeza,
ansiedad,
miedo,
dolor.
Por la familia,
Mis amistades. Por mi hogar. Y les queremos decir
Que tengan fuerza.
Que no hay mal que por bien no venga.
¿Y qué?
¡Puerto Rico se levanta!
The Puerto Rico Title V Adolescent Health Program translated and adapted the Hope After Hurricanes lesson plan from the Alliance for Climate Education.
Please, if the Puerto Rico youth in the room are in the room, and I know you are, please stand up so that we can give you another round of applause. Why don't you come on up and bring your flag? Come on. Round of applause for it. Thanks again for sharing your personal stories, and I know we'll all have a chance to interact with you throughout the conference, and we look forward to doing that too. Thank you. All right. So it's time to go to the party now, and the exhibit hall is open, so let's meet each other in there and talk.